This 18th ECDC EACS webinar on Mpox. It's great to connect with you again. The last time we met was pretty much exactly 5 months ago, 6th of December, and with EACS, Esteban and Sanjay and Anastasia here from ECDC, we thought it would be important to connect with you again. We've received some messages from some members of our network asking questions if we could do this again. Partly because of some concerns about the summer season approaching, how are we preparing ourselves, etc. So we thought it would be timely. There's much more evidence out there today. So we'll see in the future whether or not we keep posting these, maybe not as often, but frequently anyway, up until the summer comes at least. Please know that this is being recorded on Zoom, and we will make this recording available on EACS website following the meeting. So today we have a great webinar. We have my colleague Lina Norlander, who will give an update from ECDC side. We produced an updated document a couple of weeks ago, and she'll give you some new EPI update figures from our region and some of the, not all the conclusions, but some of them, especially related to vaccinations that we wanted to focus on. And then very pleased to have Dimitri Daskalakis from the White House response team, who will give us an update on how they're preparing for the summer season in the US. And we think that this will last around 30 minutes, these first two talks, and that we'll have a proper 1-hour discussion, panel discussion. Some of these names, Will Nutland has been a frequent panelist for our meetings. We are super happy to have Will back. Alexandra, who's the head of the HIV/AIDS unit at University Hospital in Geneva. Meg Doherty from WHO headquarters, who we had hoped to have on December, but couldn't join then. So we're super happy to have you, Meg, and of course, Demetra. So we have prepared some questions, but we really want this to be interactive. So please do feel free to raise your hands, add questions, and ask whatever you wanted to these great panelists, and we'll take it from there. So I will stop sharing my slides, Lina, and then I'll hand over to you, Lina.
All right. So yes, my name is Lina Norlander, and I work with Tamer on the team, and I'm going to give you an update from the ECDC side on the EPI and our latest documents. So we are now collecting and reporting data on a monthly basis, which means that, unfortunately, the data I have is from April 4th. We are expecting a new update in a couple of days, but what I can present to you today is only from April 4th. And this is the EPI curve as looks quite familiar to you probably by now, and very few cases reported in the most recent weeks. So up till today, we've had, or up to 4th of April, we've had 170 cases reported in 29 EU countries. And about WHO reports globally about 86,000 cases. 98% of the cases in the EU EEA have been male, 65% aged between 18 to 40 years, primarily MSM, and 1.2% required hospitalization. There have been 6 deaths and 8 cases admitted to intensive care unit. 38% of the cases reported have been HIV positive. So overall, there's a decreasing trend globally, and the highest numbers are reported from WHO, from the Americas and Western Pacific regions. So from now on, ECDC is advising countries to set up testing and reporting to detect cases and clusters quickly. So kind of nationally to have a rapid reporting system and to increase awareness among clinicians that they need to be on the lookout for monkeypox, Mpox, and test and report. To ECDC, countries are only requested to report monthly. And in addition to that, they are requested to do what we call event-based reporting. And that means alerting us through a special messaging system if there are significant changes in numbers, any reinfections that are reported, or new groups affected. So we are keeping our finger on the pulse, but the regular reporting is going to be monthly. So as Tamer mentioned, we published this document a couple of weeks ago, and it covers an update on vaccination, surveillance, testing, contact tracing and partner notification, infection prevention and control, communication and community engagement to underpin all those other efforts. So I encourage you to have a look at that document. I can't go through it in detail today. I'm going to focus on a couple of bits of it. And as we were preparing this document, we looked at the scientific update, kind of the literature on a few issues. And I wanted to mention one of them today, which is pre-symptomatic transmission. And there is evidence that there is pre-symptomatic transmission from Mpox cases. And this comes from a couple of different types of studies. So one is a modeling study based on UK contact tracing data. And here they compared the serial interval, that is the time from the symptom onset in the one case to the symptom onset in the second case, if they infect each other. And then comparing that serial interval with incubation periods. So this looking at a bunch of serial intervals and a bunch of incubation periods. And there you can figure out how much pre-symptomatic transmission occurs, because if the serial intervals are shorter than the incubation periods, that's the conclusion that you draw. It's a bit tricky, and I don't have time to go into it in detail, but that's one type of evidence that we have. Then we have studies on linked transmission pairs, and that is when people know exactly who infected the other, and they can look at what time that infection occurred. And in 10 out of 13 pairs in one study, they had documented pre-symptomatic transmission. And in another study, there was 5 out of 18 pairs that had documented pre-symptomatic transmission. And finally, there was a viral shedding study, and that's when they took daily swabs from people who have been exposed to Mpox. And every day they took swabs, and in 5 out of 6 people, viral DNA was detected before they started having symptoms. And in 2 of those people, it was up to 4 days before symptom onset. And they also, in 3 cases, isolated replication-competent virus. So I have the links here at the bottom of the page if you want to have a closer look. So I want to focus a bit more on vaccination. Unfortunately, our vaccination expert colleagues have competing commitment right now, so I hope to do justice to their hard work on our document. Primary preventive vaccination, you all know, should be targeted to groups of individuals at high risk of exposure to infection. And the level of risk of individuals and the epidemiological situation in the country could be used to help prioritize vaccination. And we ask countries to consider prioritizing vaccination among individuals at substantially higher risk of exposure. That includes gay, bisexual, or other men or transgender people who have sex with men according to a risk assessment based on certain epidemiological or behavioral criteria. Recent history of multiple partners or plans to engage with multiple partners, attending sex on premises venues, group sex or chemsex practices, use of or eligibility for pre-exposure prophylaxis for HIV, recent history of bacterial STIs, and a few other risk behaviors. Workers in sex on premises venues should also be considered if they handle soiled linen and other items closely. Sex workers and other people at risk of occupational exposure as listed here. So primary preventative vaccination should not be considered only on the basis of higher risk of severe disease, only if those people are also at high risk of exposure to infection. In terms of post-exposure vaccination, the priority group target groups are close contacts of cases, sexual partners, household contacts, healthcare workers, and individuals with other prolonged physical or high-risk contact. And if there's limited supply of vaccination, contacts with a high risk of developing severe disease, if infected, should be prioritized. And those are children, pregnant women, and immunocompromised individuals. So if they've already been exposed, you should prioritize those at higher infection. Post-exposure vaccination is best given within 4 days of exposure, of the first exposure, and that's when you have the highest chance of preventing infection. But you can still give it up to 14 days after exposure, and that helps them kind of reduce the symptom severity if they are infected. In our document, we've collected data on vaccination doses administered, and as you can see here, countries started administering vaccination at different times during 2002. And the countries that have vaccinated the most people are France, or used the most doses are France, Germany, and I think Spain. So you can have a closer look there if you're interested. We've also included studies on vaccine effectiveness. There is sort of about 10 or so, and a lot of them are published at the very end of 2002, so quite recent data. And I've included hyperlinks there to the studies if you want to look at them more closely. And there is also ongoing studies, one's funded, coordinating by European Medicines Agency in German clinics, a multi-center prospective observational cohort. Complementary then is the one in the US, an observational cohort using large healthcare data sources. So based on the data that we have so far, we state that vaccination is a complementary intervention to other measures, and that individual level vaccination should not replace other protective measures, and those vaccinated should continue to avoid close contact with people who have Mpox. And the limited evidence available indicates that the vaccine provides protection against Mpox virus, that infection can still appear after a dose, but illness appears less clinically severe and hospitalizations are reduced. And the evidence indicates that 2 doses provide the highest effectiveness, and therefore vaccination with 2 doses should be considered for all eligible individuals. And considering the limitations in vaccine supply, both primary vaccination and post-exposure vaccination strategies may be combined, focusing on the one hand at those on higher risk of exposure, and on the other hand, those who are close contacts of cases. And that national decisions on the best strategies and target groups should be undertaken by member states according to the local epidemiological context. We also have some knowledge gaps. There are many more other than these, especially on the clinical side, but some of the ones that we thought most important from the public health side are the long-term effectiveness of vaccines, the duration of natural immunity, and the risk for reinfection. Data on risk perception and linked to behavior change, the role of asymptomatic infections, and also whether self-sampling can be effectively used to scale up testing strategies if needed. So I'm going to just finishing by mentioning we have collected together with WHO a catalog of all different resources on Mpox mass and large gathering event preparedness. And also in the document I mentioned earlier that we published 2 weeks ago, we have just linked to all the resources as well. And I want to finish by thanking the ECDC Mpox team and the consulted experts in different countries and at different agencies. So thank you so much, and over to you, Taimur.
Thank you so much, Lena, for that excellent overview. If anyone has any questions, please feel free to ask now, 1 or 2 questions, or if you prefer, write them in the chat. Lena will be remaining on the call, so can help answer some of these questions on the chat. So I see nothing in the chat now, so maybe we could move over now to Dimitri's talk. So just mean if you could share the slides, we will hand over to Dimitri. And oh, sorry, Esteban, do you want to say something? Sorry.
No, just introduce Dimitri. We are very lucky having him again. Dimitri is the Deputy Coordinator for the White House National Mpox Response, and he can talk us about the experience in the US firsthand, and we are eager to listen to him, knowing what's up to now and in the near future. Dimitri?
Thank you so much, Esteban, and thank you, Taimur. I really, I am lucky to be able to join you, so thank you so much for having me. Really excited to share where we are currently and also what our plans are from the programmatic side as we approach spring and summer. Next slide, please. So I'm going to start with a brief epidemiological update just to give you a sense of where we are, and also share some novel kind of epi data that is now publicly available. But I wanted to make sure that you all were aware of it as well. So in terms of the US situation, these data are updated as of April 26th. Our updates are now going on an every 2-week tempo, so more data coming in the next week and a half or so. So the United States is up to 30,361 cases. To date, we have had 42 deaths. I'm going to have you file that number in the back of your mind, because soon I'll be sharing some information that was recently published by CDC that focused on the 38 deaths that had been reported prior to the time of publication, with a lot more epidemiologic detail around what their stories were. Next slide, please. In terms of where we are in the outbreak, this is our epidemic curve in the United States. I think it looks not dissimilar from what we just saw presented on the previous presentation. I will note one important milestone, that the United States on the week that ended on April 26th achieved its first 7 days in a row with no reported Mpox cases. So that is a good news milestone that we are obviously tracking. Again, I don't expect that to necessarily stick, but again, if you can get to 0 once, it means that you have the potential to stay at 0, which I think is exciting news. Looking at the demographics of our outbreak, the majority of cases are in the 31 to 35-year-old range or younger. The young cases, we did release information about them early on, have tended to have not very severe disease, and so the folks who were under 18 had very few complications to date. We also do have cases that are older, and again, those tended to have some additional complications. Looking at our race and ethnicity, we saw trends of a very rapid shift of the outbreak from one that was sort of representative of our demographics in the US to one that was overrepresenting Black and Latino individuals. So all said and done, looking at the entire course of the outbreak, about 60% of the cases that we are seeing, that we have seen in the United States are among Black and Latino individuals, so overrepresented compared to their proportion in our population. In terms of gender identity, the majority are cisgender men. Our percentage is 95%. About 3% are cisgender women. Trans men make about 0.2%, trans women about 0.8%, and other gender identities or gender diverse individuals about 0.9%. Next slide, please. I also wanted to highlight, if you haven't seen it, that along with our case-based surveillance, we actually have implemented environmental surveillance of Mpox in the United States using wastewater. And so we have over 500 sites in the US that will sample wastewater, along with other work that's happening in wastewater. So added on to that work is Mpox detection. I'll tell you that we're learning how to use it with the community and public health officials locally as we move forward, since it's really a novel strategy at assessing the activity of Mpox in the US. As of the last update, again, also on April 26th when the website was accessed, there's one site in the US that has consistent detection, and then one site with intermittent detection. I'll tell you, though, I don't have a trend that I can display. The intermittent sites come and go. The consistent site's been consistent for a while, and there appears to be some good explanations, including someone with immunosuppression and long-standing shedding, which is very interesting in terms of the potential sensitivity of this tool. So we'll learn more as we go forward in real time and in real applied public health, but this is available publicly, and this is updated weekly. Next slide, please. Given where we are with cases, I thought it was important to just share some modeling data that has come from CDC. They asked in their mathematical model, how high do you need to go in terms of population immunity to prevent an outbreak? And is there a threshold where an outbreak won't happen or the size of the outbreak changes? And so what they found was an inverse linear relationship between population immunity and the risk for another outbreak. So the higher the population immunity, the less likely there will be an outbreak. That's reflected in the left-sided graph. They also found a spot, 30 to 35% vaccine coverage among our estimated population who could benefit from the vaccine. Under that threshold, the model indicates that we could potentially have outbreaks equal to or larger than the one that we experienced in the last year. And so that really is helpful in terms of framing where we are with our vaccine mission, since obviously we would like to see vaccine-generated immunity as opposed to infection-generated immunity in the population as a shield for future or larger outbreaks. Next slide, please. Which leads right into the story of where we are with vaccination in the US. So as of April 25th, when the data was most recently updated, we have about 1.2 million doses of vaccine that have been administered, all Jynneos vaccine, all modified vaccinia Ankara BN platform vaccine. So no or little ACAM 2000 was administered. This graph shows you first and second doses. Light blue is second doses, dark blue is first doses. So you can see again that unfortunately our vaccine trend mirrors our good case trend, which is out of sight, out of mind. As cases become less prevalent, we are really hearing more and more that we're not seeing that same excitement about vaccine that we saw when this was felt to be more of an urgent issue domestically. And so I'm going to talk a little bit about what we're doing to stimulate some activity there. I'm not covering our vaccine guidance. I'm happy to answer that in questions if it comes up, but it's not that different than what we heard earlier. So I'm happy to review that if folks have questions about who we are recommending vaccine for in the US. It's been pretty stable for a while. Next slide, please. One of the other important pieces that we released in terms of data, along with the modeling, was a high level of transparency for what we think the vaccination rate is among populations who could benefit from vaccine in our individual states and jurisdictions. And so available online and updated monthly is a view of first and second doses based on state, and also a couple of cities that are large and have their own direct supply of vaccination. You'll remember 35% is our sweet spot in terms of trying to achieve a vaccination level that will prevent a large outbreak. Of course, we'd love higher. Looking at first dose vaccine rate in the United States, or vaccine coverage, it's just squeaking by at 37%. We know that 2 doses are better than 1. Fully vaccinated are way under 35% at 23%. So our vaccine mission continues. Next slide, please. Also wanted to share interesting data around equity issues that we're experiencing with vaccination. So this is a graph that shows a vaccine to case ratio. And you can see that there are differential lines based on race and ethnicity. For every 1 white person with infection, 43 white people were vaccinated. For every 1 Latino person with infection, 17 Latino individuals were vaccinated. And for every Black person with an infection, 9 Black folks were vaccinated. So it really is a metric to be able to track how we're doing with vaccine. Though I had to remove the slide because of the size of my deck, I actually was going to put this right next to our PrEP to need ratio in the US, which is number of people on PrEP over number of new HIV diagnoses, and it looks identical. So really raising again to our attention something that we know, that systemic racism is a significant barrier to access as well as to implementation of important prevention strategies. Next slide, please. And I wanted to then, again, keep telling the story of how Mpox has entered our HIV syndemic. Next slide, please. So just as a reminder, click please, that Mpox HIV STIs appear to have a synergistic effect just by the fact of who they're being feeded and the fact that the diseases seem to interact biologically. That is then worsened by the social determinants of health, including racism, and you'll see soon housing, transphobia, homophobia. That the force of those social determinants, click please, galvanize this into a way more powerful force, a syndemic, next please, that then creates increased impact on our affected population. Next slide. So historically, we actually watched Mpox enter the syndemic. So early on, we saw that 38% of cases of Mpox were seen in people living with HIV, which is the exact number I think was just presented in prior data. We then also learned that those individuals that had dual infection had more severe outcomes, more hospitalization, et cetera. A month after that, in October, data were released on our 57 sickest patients who were admitted to the hospital. 82% of them were living with HIV, 72% had a CD4 count of less than 50, and less than 9% of them were taking HIV medication. Almost 70% were Black, and 23% were homeless. So we have the conditions, infections that interact and social determinants of health, making the outbreak significantly worse with worse outcomes. Next. We then have the international case series. I'm not sure if Chloe's listening, but Chloe, this is your paper, really important, and I'm sure a lot of you all also contributed. really supporting the notion that people with a more weakened immune system were more likely to have severe outcomes of Mpox. All the deaths that were reported in this case series all happened in individuals with late stage HIV with T cells less than 200, and also associated worse outcomes with higher viral load. Next slide, please. And that plays forward into the US data that was released a couple of weeks ago about the deaths in a recent MMWR from CDC. Click, please. And in this review of the deaths, which really mirrors what we saw with the severe cases, most of the folks who passed away were Black, really tracking with what we saw in the hospitalizations. 87% were Black, 95% were cisgender men, and of the 24 individuals for whom we had good data on HIV, all but one had a T cell count less than 50. The one that didn't had a T cell count less than 200. Click, please. And then focusing even deeper, click, that we also have regional disparities with more cases happening in the South, as well as a high percentage of individuals reporting homelessness. Now, just last week, Los Angeles County asked a different question. What if we look at homelessness and Mpox infection? And they found chilling data, which was that when asking the question, who did we see Mpox, who had Mpox, who was homeless, 60% were living with HIV. 49% of them were virally suppressed, meaning the majority were not. And 21% required hospitalization. Almost all were cisgender men who have sex with men. So really raising again the role of the syndemic in this outbreak. Next slide, please. Which then leads me to sort of talk about, again, how we've responded. Click, please. So what we've done is really created lots of strategies through HIV, STI, housing, and mental health funding to try to support the Mpox response. So we did this in the fall. I can only imagine what the outcome would have been had we not been aggressive in creating a syndemic response, given what we were seeing in the data. Next slide, please. Which leads me to where we're going for this next season as we approach the summer. Next slide. Next slide. So given the syndemic nature of this, what we've done is create resources that really focus not only on Mpox, but all of the things that LGBTQAI+ people need to know as they approach the summer Pride season. And so this Get Healthy and Ready for Summer 2023 is our drumbeat and our mantra. It has traveler's health, travel information, sexual health information, HIV, STI, Mpox, Shigella, meningococcal disease, all of the things that are challenging the community, COVID information, and then also an entire section on overdose prevention, given that epidemic in the US. Click, please. In addition to that website, we've created an entire battery of resources that I will show you who we're sending to across the US that really focus on all of the syndemic components, again, from HIV, STI, all the way to overdose. We have shot several videos. We crowdsourced 16 questions about Mpox and the vaccine, and we keep crowdsourcing them. So we keep adding to this list of presentations, but several videos that actually respond to community questions around the vaccine. We have a new vaccine finder. People are able to put their postal code in, and it tells them where to find vaccine, and a new palm card that hopefully will be handy as we approach summer and the summer fun season. Click, please. And so we're doing it and then telling everybody about it. And so this is just a slide that is quite an interesting mix of organizations, ranging from CDC all the way to Kink Down South Weekend. And so we really are working to make sure that we get the word in lots of places. We're working on our house and ball community. We have events scheduled with Grindr, really moving forward, including some folks that we didn't expect to necessarily have to partner with. We're working with Healthcare for the Homeless in the US, et cetera. So whether it's nightlife, all the way to organizations that serve homelessness, we're getting this message out in preparation for spring, summer. Click, please. And that brings me to the end of my deck, so I'll hand it back over. Thank you.
Thank you, Dimitri, for this outstanding review of the situation in the US. Just a quick question. You have shown clearly the inequalities in access to Mpox vaccination and also probably to care, and how these are coincidental with those of HIV and other health issues. So because this is not consistently seen in other countries, particularly in Europe, because of the universal health system, we are interested in knowing to which degree are you managing or trying to resolve this situation? Is it by empowering the potential persons who may be affected? Is by increasing the surveillance in the clinics? It is by getting the whole population, the whole society in the US involved in the interest of this disease? What are the general trends?
Yeah, so I'll start by answering that is our hardest nut to crack in the United States. These fault lines that we see in the way that care and service are delivered are deep and long-standing. And so many of the things that we're doing in Mpox and also in HIV are really addressing where public health can have impact, but ultimately these are all of society interventions that require really significant focus on all of the equity-related issues that relate to race, ethnicity, gender identity, the sexuality and sexual orientation. And so, again, realizing that much of what I'm going to tell you is a Band-Aid, because the fault lines are the fault lines, and really sort of thinking about that all of society needing. You can sort of follow what's happening in the U.S. to see that we're in a place where policies in some locations are going to make it even harder for us to reach the people that we need to reach, because their identities are not being celebrated, in fact, are being vilified. And so I think we have a very significant challenge that we are looking at today. But one of the things that's really important is, like, Mpox was like a sort of shines a very bright light on where we have inequities. And so if you think about the people who died, and let's focus on that for a moment, they were not touching our care system. No matter what CDC was doing, no matter what Ryan White was doing in HIV service delivery, these folks were not engaged. And so what we did that now ends up being, like, thank God we did it, was that we connected with mental health and with housing. And so thinking about the other sort of in the hierarchy of needs, people really need housing. And so they may touch the system in places where now the system is connected to the Mpox mission. So if they're looking for housing and they're living with HIV, or they're homeless and they don't have HIV, we have resources for them to not only deal with Mpox, but also to link them to care and service for HIV. We did the same with SAMHSA, which is the Substance Abuse Mental Health Service Administration in the United States. They touch drug user health as well as mental health services. And so people who are drug users may touch the system there. People with mental health issues may touch the system there. That is all has been aligned with the Mpox mission, but even in doing that, we still haven't succeeded in terms of preventing these bad outcomes. So I think and the next goal is, how do we get more people vaccinated? And that really is, you sort of saw our strategy, create stuff that is sort of pleasure-based, excitement-based, fun-based, and then really focus on getting it to the right people who are trusted messengers. And so I have an example. On the slide, there's an organization called Deviant. Deviant is an organization run by Black men. They have parties. They have large social gatherings with thousands and thousands of young Black men who come. They have a public health heart. And what they're doing is actually becoming a non-for-profit so that they're able to get funding through public health. And so we're partnering with them because people trust them. And so though I would love to say that CDC and the White House are trusted messengers, not always the case. And so we're also taking that, we're sort of doing that work as well to try as a Band-Aid to get information to people who are magnifying the message.
Excellent,
so
excellent.
That is a crazy times.
Well done, well done. So a new need, but also an additional opportunity. So yeah, that's the way of working. So let me hand over to my colleague, Dr. Sanjay Bagani, who will continue with the panel discussion. Sanjay?
Thank you, Esteban, and thank you, Lena and Dimitri. That was really fantastic. It's really got us off to a good start. There are a number of questions coming through the Q&A panel and through the chat, and so please continue to forward the questions. And whilst I try and kind of just very briefly introduce the panel, so you've met Lena already. Lena, please stay and join us for the panel. Thank you very much. Dimitri, thank you for the fantastic presentation. We also have with us Will Nutland. Will is well known to all of you. He's the co-founder and director of the Love Tank and has been involved very heavily in the community response, not only in the UK, but across Europe as well. We also have with us Alexandra Kalmi, who's also well known to you all. She's a head of the HIV/AIDS unit at the University Hospital of Geneva and has been involved very heavily in the clinical response to monkeypox and in some of the trials, both with vaccination and tecovirimat. And last but not least, of course, great pleasure to have Meg with us, who wasn't able to join us in December. Meg Doherty, who's the director of the Global HIV, Hepatitis and STI programs at the World Health Organization. So thank you all for joining us today. There is a couple of questions that have come through on the Q&A that we should try and tackle at the offset before we move on to a wider discussion. And so first question for both Lena and Dimitri, this is one that came through the chat, which was around monkeypox, Mpox infections in transgender people. And the question was that, do we have an idea of what this accounts to in terms of proportion of the transgender community in these areas where these infections have been reported? In other words, you know, is there a higher risk or a higher proportion of transgender people with Mpox infections? So, Lena, Dimitri.
Yeah, on the ECDC side, we do have a variable asking about sexual identity, and that's very poorly reported. Only about 13 cases, I'm just being told. I'm chatting with our data analysts actually as we speak to see how, because basically we don't really have good data reported on sexual identity. We of course have sexual orientation. But even if we were to have that data, you would also have to know the denominator or the population size in the different countries. So I think it's a really tricky question to answer, but clearly very over.
Yeah, I absolutely agree. Dimitri, any idea in the US? And I know the denominator is going to be the question that's going to be difficult to answer.
So I'm going to sound so much like Lena here. So we actually, the variables around gender identity, early on, we were getting very complete data. And then as time marched on, those fields tended to be less and less filled in by local public health. So our estimates of you know, just about like just under 3% of people who identify as transgender, whether it's trans men, trans women, or other non-binary folks, really comes out of sort of about 3% of the 36,000 or so people we have information on and can report. Again, same problem with denominator. We don't really have that answer. There's also some complexity in terms of how gender identity is obtained in some jurisdictions, where some of the surveillance data will misclassify a transgender woman, as example, as a man who has sex with men, and so it's hard for us to estimate. And so I think we suffer from the same issue as Lena. I think again, you know, the challenge with us, and I think it's probably not dissimilar, is that since there are so many jurisdictions with their own strategy for data collection, and because some of the data around sexual orientation, gender identity is not mandatory or standardized, we get patchwork. So I think we suffer from the same problem. I think it's underreported. So I think that our 3% is likely an underestimate of how many people who are of a who are transgender or gender diverse have had this infection.
Thank you. Yeah, and I completely agree. And I think this is going to be a difficult question to answer, but we ought to make an effort to try and monitor this, because this may be a group that requires intervention for the future. So let's move into a bit of a discussion. We've had some pre-prepared questions, and you know, so the first one, and I'll try and bring as many people in as possible. So, you know, we're almost exactly a year from the first cases of sustained transmission of clade 2B Mpox virus outside of endemic areas and outside of travel-related infections. And so, you know, we've seen a pretty rapid response, certainly in Europe and in the USA, and our case numbers are really down, although the same is not true for other parts of the world. So in the panel's opinion, you know, the important question was it risk behavior modification, community sensitization, or prompt vaccination that led to the decline in the cases that we've seen in the Northern Hemisphere? And that, you know, what are going to be the important issues that we're going to need to tackle as we move into the summer. And I'm going to start by bringing in Alexandra to try and get a clinician's perspective on this, and then we'll move on to Will and Meg. Thanks, Alexandra.
Yeah, thank you very much. Thank you very much, Sanjay, for this interesting question. So I would like to answer you everything matter. So certainly changes in risk behavior played a major role in the decline in Mpox cases seen in the Northern Hemisphere. I think way back in August 2022, a study conducted by the CDC highlighted the significance of reducing one-time partnership in lowering the risk of Mpox. So we knew that already since August 2022. And I would like to also emphasize the community response was really exemplary. I think Dimitri has shown that very clearly. He was one of the protagonists of this community response, but this is really something I would like to emphasize, like for HIV. I mean, community response has been really essential. But I mean, in a survey we did here in Switzerland in a small scale, we showed that the change in risk behavior was declared in around 50% of the respondents. So not everyone really has this change of behavior. So the question is about the role of additional measures. So let me just take the example of Switzerland. In Switzerland, we had a sharp decline of Mpox cases already end of August and in autumn, but the vaccination started only in October. So at least in my country, it's quite clear that vaccination has nothing to do with the decline of the sharp decline, not you know, like a Gauss curve, but really the sharp decline of the epidemic. So probably there is a mix of the change in behavior, but also the acquired immunity through infection to some extent in the high-risk population or very high-risk population. And the vaccination came in many countries a little bit later, and in some countries that didn't even come, as for example in Brazil, very, very late. So I would like to answer you, it's probably a mix of everything, but as Dimitri showed, the 30% kind of threshold are probably an accumulation of vaccination-induced immunity, natural infection immunity, and risk behavior changes, I would say. Thank you.
Thanks, Alexandra. So, you know, and just for a couple more minutes, I'm just going to push you a little bit on this, and then we'll go to Will in a second. So just had a comment from Mike Yule in the chat and saying, you know, and we've seen very similar things in the UK, by the way, Alexandra. So we saw the data in London where we saw a sharp decline in cases before vaccine uptake maximized out. And so Mike was asking, you see, if risk behavior was changing, we didn't see a reduction in chlamydia or syphilis or gonorrhea cases in that same context. So what was different? Well, was there a differential risk behavior in terms of monkeypox acquisition?
Yeah, sure. I mean, maybe there are some different risk factors. With Mpox, it was really a very, very high risk population. 38% of HIV positive, even depending between 38 and 50% of HIV positive populations were affected. So I think this may account for the difference between other STIs and Mpox. So there are risk factors to acquire gonococcal infection or chlamydia infection that may not be exactly the same as the very high risk population that we had in this outbreak in 2022 with Mpox. Maybe this is an element of the answer.
Thank you, Alexandra. So, Will, can I bring you in here and you know, let's talk about the sort of community response and you know the amazing work that you and the team have done, and tell us a bit more about how we're gotta get ready for the summer.
Sure. So I'm really struck by what Dimitri has just presented to us, and thank you and congratulations for your what appears to be a whole system leadership approach. I'm sitting here in East London. I don't feel like I can really speak on behalf of the rest of the UK or the rest of Europe. But the thing that has driven me to despair with the England health system and our monkeypox response has been how fragmented our response has been. And Dimitri has just spelt out very, very articulately how you are doing the Get Healthy and Ready for Summer 23 program of work. A little bit of a plug here. My organization is running something called Ticks Keys Phone Vax Ready for It. So you can go to queerhealth.info/ready with a very, very clear sense that we're asking people who are going on spring or summer vacations, people who are traveling, people who are going to kink and fetish events, not only to consider Mpox vaccination, but Hep A and Hep B and HPV vaccination. And this has a strap line of for Kinksters by Kinksters. So very much kind of old school community owned kind of kinky approach to encouraging continued uptake of Mpox vaccination. But, and here's why I'm impressed by the White House whole system response. Our UK Health, UK HSA, NHS England announced just 6 or 7 weeks ago that from the end of June, they will cease to offer first vaccinations, and in July we will cease to offer second dose vaccinations. And I keep hearing through the numbers of meetings that I go to that gay and bisexual men and other MSM and people who are eligible for Mpox who have not been vaccinated aren't trying hard enough. And actually what I'm hearing back from those guys is if the NHS, if UK HSA is now saying that Mpox is such an insignificant risk that a national vaccine program is being wound down, why should I take time out of going to the pub or having hookups or going to school or working 3 or 4 jobs? Why should I take time out to go and be vaccinated against something that all of the health systems are saying is not important enough for a national vaccination program to continue? And I think this is a massive system problem. And again, as Dimitri has very articulately described for the States, and I think it's the same for the rest of the world, we're looking at band-aid solutions rather than system-wide approaches to Mpox. And, you know, as again, Dimitri has shown that you could kind of take a whole set of data from the States and you can look at PrEP inequalities and it mirrors Mpox inequalities. We're seeing exactly the same thing here in London. And, you know, guess what, folks? In a year or 2 or 3 years' time, we're probably all going to be back having almost exactly the same conversations with some other infectious disease that is impacting on exactly the same sets of people, because we haven't had the political willpower to sort out these massive systemic inequalities that time and time again are impacting on people that I love and that I care for and people that I have sex with and people in the communities around me.
Thank you. Well, and you know, you make a really important point about the UK, or at least the English response to the vaccination program. And you know, we have been having chats with the UK HSA about this, and they are keeping this under review. So let's wait and see what pans out in the next couple of months. Meg, can we bring you in terms of the WHO's kind of preparedness for where we're going globally with this? Thanks, Meg.
Thanks again. And I'd have to say that before coming on, I made sure that I checked in with all my other WHO colleagues who are really deeply involved in all of this work since the very beginning, especially those like Rosamund Lewis and others who have been working on this since since the outbreak started, and I think are speaking the same language that we've just heard from Will Nutland, that we just have not yet been able to do, not just on all of US, but in all of the world approach that makes sense, that will be, and I think we're quite aware that there are so many, as people would say, polycrises happening in the world today, that as the cases diminish, the sort of political push to be able to keep the fake or the public health emergency of international concern moving will be more and more difficult. So from the WHO's perspective, I wanted to say one thing, just going back to what was the impact. I think we've looked at it and we think it's three areas of what caused the reduction would be, and perhaps grading them as an infection induced immunity, we think may have had the greatest impact, as well as behavioral change and then vaccination. But will those have the same impact going forward? I think that's the thing that we don't know, because that infection-induced immunity, as Alexander was mentioning, happened very rapidly among different populations, among populations that were incredibly high risk. Now we may have more of risks that are identified in people who have been left behind always. And as Dimitri was showing, the really terrible examples of those who are left behind because they're not accessing HIV care, HIV prevention, home, those who are unhoused, etc. And I do think that our approach from WHO, we are starting to look at that as to how do we start to bring the Mpox actions and response into both our HIV programming, whether it's being able to screen and identify and have interventions at the point of care for PrEP or STI care. But as all of you know, STI care is so poorly established around the world that trying to then have Mpox be cared for at STI clinics, I think we may find ourselves in a real difficulty of being able to have a global response that really reduces the morbidity and mortality from Mpox. So for us going forward for this summer and preparing, I mean, there are many regions who are thinking not only about how do we think about elimination and what are the criteria for elimination control. So you've got that whole side, and another side of how do we ensure that we still have a public health response that brings forward the tools that have never reached some of the low and middle income countries that we should be serving. So we have a TPP for diagnostics that we have to follow up and ensure that new diagnostics are becoming available. That's an access issue. We have vaccinations that may not be reaching those most vulnerable around the world in low and middle income country. That's a concern for us. And certainly for the treatments, I think for the most severe cases, and defining what is a severe Mpox case is something we're addressing. So the other thing just to speak to as we prepare for the summer is having a bit more structure around the discussion on severe Mpox and people living with HIV and advanced HIV disease, and increasing the knowledge. I think Dimitri spoke to this specifically, but we're also now trying to stand up a process by which we can come to terms with how do we include this into an advanced HIV disease care package, but then also ensure that there is access to the the treatments and the countermeasures that would be needed during this time. So just to say, I think there's a lot of work that we're going to be needing to do just on the clinical guidance, the public health guidance, the epidemiological guidance. And we often are taking our lead from ECDC and the WHO in Europe, who are doing, and PAHO, who are really bringing things together very nicely. And we try to adapt them for the global setting.
Thank you, Meg, and yeah, you're absolutely right that as Dimitri very eloquently put it, this is going to be joined up care that need to roll out globally. So there's loads of comments coming into the chat. So, you know, for the panelists and everybody else, feel free to answer things on the chat if you want to. I'll try and take questions that are coming through the Q&A, etc., to try and bring things together. So one of the other important issues that has come up is the concept of the length of immunity after infection. In other words, you know, we have already seen descriptions of reinfection cases, but closely linked into that is the length of protection from, you know, 1 dose or 2 doses of vaccine as we go into the summer. And so can I bring Dimitri into this? Dimitri, what do you think? I mean, I'm sure we don't have all the answers to this so far, and I know your modeling data suggests, you know, vaccination at 35% might be the sweet spot that we need to hit. But how long is that vaccine response going to last? How long is, you know, is the natural immunity going to last?
Thank you, Sanjay. And I'll just make sure that everyone knows, if you're putting questions in the chat for me, I'm not ignoring you. I can't see it. The White House blocks chat. Welcome to my world. So I apologize if I'm missing questions. It's not because I'm ignoring you. So I think that really what I know about that is that we don't know the answer. And so I think that that's an important place to start. I think what's important is that we have lots of lines of investigation. I think that Meg can probably speak on that as well, but lots of lines of investigation in the US to be able to track what's happening with vaccines so we can have a better sense of where we are in terms of longevity. So we have studies that are happening in DC. We have one in LA and one actually in DRC that is asking that specific question, along with studies in duration of immunity. We also do have a study that has now fully enrolled. Lab data will be forthcoming soon. That is looking at various dosing strategies for the MVA-BN vaccine. And so it is a study that compared subcutaneous dosing versus intradermal, and actually looked at 2 different intradermal doses, the dose that we're using in the US currently, as well as a half dose. It is actually looking at vaccinia responses. So I think would also potentially have some implications for smallpox preparedness too. So that study has been enrolled and lab samples are being analyzed. It also has been bumped into also having a new arm that's going to be under 18-year-olds. The current study only does 18 plus. And so I think that, you know, we're through our vaccine, our VE system, sort of monitoring the vaccine. I'll give you a little bit of a spoiler that sometime in mid-May, a lot of new VE data will be coming out of the US, which is very exciting. So watch for that. But in terms of duration of immunity, the American Advisory Committee on Immunization Practices has not opined on the need for future doses in the setting of a natural outbreak of Mpox, as opposed to related to pre-exposure prophylaxis in the setting of work in the lab. So it's an area I think that the data will hopefully inform so that guidance around vaccination can follow. So, so again, the other part, which I'll plug, is if you're interested, we did this large research gathering in the US. It was virtual. We had about 800 attendees. And all of the different components of the US government, from CDC all the way to the Department of Defense, contributed to these videos that we have online. And they actually talk about the various research that was being conducted domestically and internationally, supported by the US government. Those videos, we have a whole video on vaccine that specifically talks about what the areas of investigation to look at the effectiveness of the vaccine as well as duration. Long-winded answer, Sanjay, sorry.
No, that's great. And if the video is available, if you could send the link, we'll put it out to our audience. I know you can't access chat, so don't worry, but we will get this through to people.
I'll email it, it's easy.
Fabulous. Alexandra, what do you think? You know, what do you think about, you know, sort of infection-induced immunity, vaccine-induced immunity? How long does it last? Are we going to need to do more work around this? Clearly we are, but what sorts of work?
Yeah, thank you. I think the main question now is not to ask whether the Mpox will disappear or not. We know that the Mpox will stay. We know it's circulating, it's a zoonosis, there is an animal reservoir. So there is no chance we can get rid of this virus anyway. What we want to know is whether we can get rid of an outbreak or whether we will have some sporadic cases and clusters as the one that has been described in France several months ago. And to answer those two questions, I think, is vaccine coverage enough? Is it efficient? Is it durable? And what I think is important is that we have not much data, and most of the data that we have are based on, smallpox as a main, smallpox and vaccinia virus vaccination. And the other thing is, from what we know from the MVA vaccine, the B cell immunity is not very durable. We have seen weak answer of neutralizing antibody. So we are counting now on the T cell response, but we have very, very few data that allow us to say that this will be a very strong and robust T cell response to Mpox. And what did happen in the last 2 months is this 6 documented cases, published cases, as of today, and to the best of my knowledge, 6 reinfection cases. And if you look at these 6 cases, the reinfection was mild, which is a good news, but it may be a bad news because if you cannot detect the infection, that will be a bad news for the epidemic. But it's a weak and post-symptomatic infection, but it occurs between 2 to 7 months after the first documented Mpox infection. So very rapidly, I mean, the natural immunity did not last very long to allow this short-lived reinfection in people who were not immunosuppressed. None of the cases were immunosuppressed or untreated HIV positive patients, for example. So this raises really very important question. And I think what Dimitri said, we need to make research, we need to follow this cohort of patients. And the final question is, shall we suggest a booster dose, or shall we suggest to vaccinate also those who have had a natural infection in July or August 2022? And this for me is open questions. So far as I know, there is no public health recommendation of revaccination or booster vaccination, or the vaccination of people who had an Mpox infection in summer. And this is something I really would like to share with the group here today. We are considering this strategy here in Switzerland, try to propose a booster vaccination to people and to document, of course, the neutralizing antibody and T cell responses. But I would be very happy to have your input in that, because I think this is how we can get prepared for summer. We certainly can ask everyone to be aware, to be careful, etc., but even better if we can add some other tools to be sure we can prevent any outbreak in summer 2023. Thank you.
Thanks, Alexandra. And I think you pose a really important question that's often asked of us clinically, and a question that we have asked the JCVI in the UK, which is, if somebody has had a natural infection, do they need vaccination? And if they do need vaccination, do they need 2 doses of vaccination? And I have to say, the answer is unknown, and they have actually skirted around the issue and sort of said, give it a few weeks and then you can vaccinate, which is what we have been doing. But this is really crucially important, and I think this summer will be crucial in terms of seeing what pans out. Meg, what's the WHO position on vaccination in terms of those that have had a previous infection?
Yeah, I think I was just looking currently at the SAGE, who is the body that looks at vaccination. And to be honest, it hasn't yet made any kind of decision regarding revaccination at this point in time, per the information I have right now. But we are involved in the Loire Valley small cluster, and I think there's a desire to get more information there. And I think just adding on to what Alexandra was saying, there's a couple of hypotheses there that, are these evading the vaccine or immune evasion, or is it really a decrease in the immunity that at 6 months after the vaccination? And I think if there's really this concern for decreasing immunity post-vaccination, and certainly because these were not immunosuppressed or immunocompromised people, I think we would have a high concern for wanting to ensure that those who are immunosuppressed would have adequate immunity. And I don't think we have enough information yet on people living with HIV, those immunosuppressed, and how well their immunity has been post 2 doses and if they need another dose. Considering what we've brought forward from for COVID vaccine and other vaccines out there, in any setting where there has been concerns about those immunosuppressed, we eventually have gotten to a point where we've suggested either booster doses or another primary dose. And I think this is a space where we'd like to be able to review the evidence as it comes forward and ensure that we're providing extra doses as needed. I think the challenge we have, which is from the comment that came in from Esteban, was what is WHO doing about ensuring that there are vaccinations worldwide? And I think this is, I'll take on the hat of taking it on the chin for WHO. I think this is a place where we have not excelled. So I just want to be forward on that, is that we have to note that we've been relying on both the donations and the efforts of the US government working with Nigeria and DRC to bring vaccines out. And I do think that we should be trying to take a stronger stance here. And so all I can say is, we have many forces within the WHO and trying to ensure that adequate testing, immunization, and potentially medicines has been a bit of a challenge for us to be able to get them to low and middle income countries. I think now we are in discussions, and more so with the relationship that's happening in Nigeria and DRC. So I think it would be great if the world writ large would give WHO a bit of a stronger push to make sure that we're responding more rapidly in this regard. And the comments from and the member states from the executive committee around the fake and the public health emergency of international concern should be holding WHO to account. I wish I could say that I was particularly in charge of that work, but I'm not. But on the other hand, it's my responsibility also to be able to raise the flag when we're not able to get the vaccines where we need to get them. So
thank you, Meg, and we're not holding you responsible for this by any means, but please do continue to raise this on our behalf at those count. And
just to mention that these vaccines right now going out are often for either stockpiling for preparation or for studies, but not necessarily for use in the general population or at-risk population, and I think in some ways we have to have the ability to have enough for the studies, for stockpiling and preparation for potential outbreaks, but also to serve those who are actually at highest risk.
Absolutely, agree more, and thank you very much for bringing that up. I think there's a huge amount of interest in vaccine and immunity and vaccine responses, and one of the plans we have for a future webinar is to concentrate on that, and so I'm sure we'll come back to this discussion again. I'm not going to hog too much of this, so I'm now going to hand over to Esteban. There's a couple of questions in a different direction that would be good for discussion. So Esteban, thank you. And thank you to the panel.
Thank you. So we have discussed over immunity and vaccination, but I would like to bring the surveillance situation, and as we have already heard and know, there are subclinical or very cases with very few clinical clues. So I wonder whether clinicians, particularly not in STI clinics, which may be more prone to detect or to be sensible to this issue, but primary care physicians or others. So My question is how this is perceived in your setting. So, Alexandra, you're a clinician. So, do you think those who are in charge of receiving firsthand potential patients with Mpox with just little clues, do you think there is enough sensitivity, or do you think it should be increased?
Yeah, sure. Mpox is no longer on the headlines. So the awareness has really declined very much among clinicians, and I can just see that every day. So the question for me is first to raise awareness that it still exists, the virus is circulating. If you have symptoms, you have to detect, and as always, you know, look, test and trace in order to detect any or to identify any infection. So that's the first part of my answer. And of course, there is a lack of awareness because it is out of the headlines anyway. And also there is also this sense that everyone has been vaccinated and there is no reason to detect an Mpox infection if someone has been fully vaccinated, which I think is really wrong. Because first in the French cluster, on the 17 patients that have been identified in January, on this 17 people, 10 were fully vaccinated in 2022. So we know that vaccination does not protect completely, that we know already from various studies that Dimitri has shown. And also we know that this response is probably not very much durable. And also, even if it was a very good vaccine, and even if we would have vaccinated the whole at-risk population, then it is normal and logical, epidemiologically speaking, that the one to whom we will detect the infection will have been vaccinated, you know, because it's like COVID. You detect COVID in all those who have been vaccinated because everyone has been vaccinated. So I think we also have to consider this 2 points. Even if you have vaccinated everyone, then it is normal to find and to identify Mpox cases among the vaccinated, but also because the vaccination is not 100% efficient. And we know that now, and it is not durable. And most of the patients will have been vaccinated more than a year ago this summer. So this is the first part of my response. Maybe the other part that I think is important to discuss is the co-infection with STIs. Among these 6 cases documented reinfection cases, most of them, if not all, have been diagnosed or identified because of another STI. So the question here as clinician is, do we have to look for Mpox in any new STI? Can we do that? Do we have the funds to do that? Can we really propose that? In my country, we will not be able to do that because patients will have to pay for the PCR test to detect the Mpox because it's not reimbursed as an asymptomatic screening, if I may. So this will be a major difficulty. But for me, the question here is, if we want to have some sort of monitoring of what happened, probably the full screening, standardized, systematic screening of all asymptomatic patients is probably not very, efficient. But maybe it's not the case if we look at STI or patient with STI, because even the case of Geneva, the reinfection case of Geneva, he had a gonococcal infection, and it was really, we don't even know now if the Mpox was a bystander, just here without symptoms, or whether this Mpox infection was at the origin of the symptoms. It's really very difficult. So for me, the issue of monitoring for clinicians is first to raise awareness among the health clinic or HIV clinics, and second, to probably propose some sort of individualized screening among people with STIs, which I think is the top risk patients. And for those, probably in summertime would be good to have rescreening of all people with documented STIs. But again, I would be very happy to have your opinion on that because it needs funds and it needs to be systematic if we want it to be really useful.
Yeah, I think we need to be open that Mpox is still here and will remain. So certainly only by looking at it, we'll be able to discover it. And certainly in those situations where Mpox can be more commonly found, and also in those populations that may be at higher risk of developing a more severe disease, I think we should be maintaining our awareness and our focus in diagnosis and reporting. So there are many questions from the audience. Oh, Dimitri, please go ahead. Sorry.
So I just wanted to echo Alexandra a bit, and also add another idea. So echoing that really educating providers is really important. I cannot emphasize enough what she said. When this falls out of the media, it falls off the differential diagnosis of clinicians. Yeah. And so it is a challenge. And so I'm just echoing that. And so along with thinking Mpox when you think of other STIs, another important track of effort that I think we need to still work on is really thinking of how we can embed an Mpox test within a multiplex test that is at least lesion-based to begin with, so that when someone sees a sore and they're unclear, is it Mpox, is it syphilis, is it HSV, is it VZV, that they can just order a test. And Mpox you get for the price of syphilis, which I think is great. So really the idea of that we could potentially have a sentinel surveillance solution if we get to the point where our diagnostics are actually looking at sort of packages of infections as opposed to one infection or another. And so this is areas that we're pursuing. I'm not sure how successful we'll be, given that a lot of the fuel in the tank for Mpox has gone away, given where we are with the numbers. But we do have an opportunity in the U.S. To get a multiplex test over the finish line because of the way that the emergency use authorizations here at the American FDA are designed for diagnostics. And so we're pursuing this. Don't know if we're going to succeed, but it would really help. So if you're not thinking Mpox, but you're thinking syphilis, and you get an Mpox result that's positive, public health action can be accelerated because you're going to detect the infection sooner. Just add it. Otherwise, everything Alexandra said, yes, yes. I fully agree. Out of sight, out of mind, off the differential diagnosis.
Good point, Dimitri. I think Lina is first and then Meg.
Yeah, I just wanted to maybe, Meg, if you have a direct response to Dimitri, I could go a slightly different.
Yeah, no, I was just going to speak to the multiplex testing. And I think if people aren't aware, there's a target product profile out there that WHO has put out, but it's about how to get the actual manufacturers interested and in something that clearly makes a lot of sense. We would love to have a multiplex test for all the slew of STIs, the combination of bacterial and viral, but we don't have that right now. And even when you look at the approaches that are taken, you could have a rapid diagnostic for the bacterial. You may not have a rapid diagnostic. You may need a nucleic acid one for the viral. But I think if there's something that we could do coming out of here where we could move that agenda, we'd be really excited to be able to move that. And in terms of, the asymptomatic high-risk groups, should we have screening? We have a systematic review ongoing about the harm reduction approaches for asymptomatic and symptomatic Mpox. And I think the sense is, just like you're saying there, that we should be perhaps looking towards sentinel surveillance in asymptomatics, linking it into either if it's PrEP clinics, HIV clinics, STI clinics, but in the general population, it may be very difficult to make the financial case for this. And I think that that's unfortunate because, STIs have really not been supported for years and years, and perhaps there's some advocacy we need to do not only with clinicians but with the donors and the public health leaders about why are we not interested in putting some funding into this area of work where we know there's so much morbidity and some mortality as well. So just echoing support for testing and multiplexing, and happy to work, see what we can do.
Thank you, Meg. And there are some questions which are related. How do you plan to screen for Mpox if no clear lesions? I have understood that a kind of maybe monitoring with samples ordered for other STIs may help. Would that mean pharynx, urine, anal? Is that okay, or do you those who are more expert consider any other for, I mean, a cost-benefit ratio?
Oh, yeah, we thought anal swab would be certainly the first one. And exactly as you said, what you do for asymptomatic lesions for GC or for chlamydia, you can just add the Mpox. We don't have multiplex, but finally it's the same sites. So without lesions, I would do this, of course.
Okay. Will, I would like to ask you about the perspective from the person who may suffer the condition. So, do you think that the feeling has relaxed, or is expecting, or is it calm but not so much? What's the feeling from the potential persons who may be at risk? Is a confidence one? It's what's it? Denial, or what's it?
So Esteban, I don't think it's denial. I think it's those issues that I've already highlighted about withdrawals of service. One of the questions that that we've all been playing around with is around global vaccine supply. And you can have as much supply as you want to have, but if your health systems, your health services are not in place to put those vaccinations into people's arms, then it's not very helpful. And I was challenged this last weekend by a gay man in London on Saturday morning who said, "Where can I go today to get across it was Labor Day weekend for us, so a 3-day weekend. Where this weekend can I go to a clinic in central London to get an Mpox shot? I want to get one. I want to be prepared. You're all championing that I should go and do this." And we could not find a clinic that was open to triage that man in to get an Mpox test. And it's going to be the same this coming weekend when we put stolen jewels on an old aristocrat at the coronation. We're going to have another long weekend when again it's going to be impossible to get people either through to a clinic or to help people find out where that information can be gained from where a clinic is open. It is almost impossible in a place like London to navigate Mpox vaccination, and it's way worse if you live outside of the capital, and it's going to be way worse, I assume, in many other parts of Europe. But Esteban, there's one thing that I want to add, and I know we're coming to the end, and we've had these conversations about potential boosters or people who have already had Mpox thinking about whether they should receive vaccination. Just in the same way as 25 years ago, there were hardcore groups of mostly urban-based gay and bisexual men who had already worked out that if their HIV positive partners were on treatments, they could not get HIV from their partners. They knew about treatment as prevention way before the Swiss statement, way before the U=U movement. There were a hardcore group of us that worked out about PEP and PrEP and doxyPEP and PrEP. There are a hardcore group of gay and bisexual men in places like London and Berlin, and I'm sure in New York, who are already working out that it makes sense to have a booster and are already working their ways around the systems. Again, in London, it's fairly easy to do in order to get a third shot, and I'm hearing of people getting fourth booster shots because they had their first shot almost a year ago. Again, this is another good example of community practice being way ahead of policy and way ahead of the curve around evidence. So I think my call is that at least we start to think about what the safety aspects are there we need to consider, and what community information we should be putting out for those people who have already self-determined that 2 vaccines will not be enough.
well taken. Obviously, I think it's very important from those who may be affected to have the willingness to move forward. That's the first step. But I think the governments and authorities should help, and also the clinics and the medical services should provide other clinical trials to test those questions in a correct way. I think Lina, is your hand raised?
Yeah. I just want to maybe quickly add to what Alexandra said earlier about the French cluster. Maybe Alexandra, you can clarify. But out of those 17, we had about 10 people who were fully vaccinated, you said. But I think half of those had a dose in childhood, and then a second dose in adults, and 5 of them had 2 doses in 2002. So I think as we learn more, I think the distinction between those 2 types of schemes, which are not used everywhere, I think will become important as well.
Thank you, Lina. Timur, I was confused with your Anastasia on your screen.
No problem. I'm a bit conscious about time. I just wanted to ask Will, and maybe we'll take this for a future webinar, Will. I don't want to rush you on this, but we talked about the need to educate healthcare providers before. And do you think there is a need to remind or educate the community again, or is that already fulfilled? And related to that, about the vaccinations, which you kept talking about, I know you spoke specifically about the UK situation or the England situation, but is there still a demand in the community to get vaccinated? And do you know anything about that beyond in the rest of the European region, for example? Do you have an indication of that?
So I don't have a sense of beyond the European region, but Tamar, I think there is a need to continue to be putting really good thought through health promotion and public health programs of work. And I don't mean adverts on the back of buses. I mean sending out multilingual outreach workers from the community to go deep into those communities where currently people are not vaccinated. And again, in a place like London, we know if you are from a Black or brown community, if you're a Latino, if you don't have English as a first language, you are less likely to have even received 1 vaccine than even 2. And we must keep that going. And our learning from the under the radar vaccine pop-ups that we've been doing is adding other vaccinations if it's possible, and adding other sexual health services alongside them is really, really worth doing. It's helping to bring people into services who right now are not going anywhere near them. And then if we can also add in support around drug and alcohol or mental health or housing support, even better. But of course, this is incredibly expensive.
Yeah. Thanks so much, Will. So I think let's bring this up and have a proper discussion around this for the next webinar. I think there are examples of still great community work. Alex from Manpower reached out to me a couple of days ago, talked about some great work they are doing. So I want to give Alex and other people the opportunity. I also know that Grindr and Hornet and others have approached ECDC about, is there anything else we can do? So let's utilize that. Let's leverage that opportunity to reach out to the community with messages in languages that they understand. So let's revisit this. I am conscious about time. So if okay, Sanjay and Esteban and Anastasia, who is here hiding behind the scenes. Let's close this meeting, and Sanjay and Esteban, Anastasia and I will convene to talk a little bit about our reflections from this meeting and see if there's a need to meet relatively soon again, which I think there is a lot of interest. We're getting a lot of questions, a lot of attendance. So let's thank the panelists, Alexandra, Meg, Will, and Dimitri. Really great input. It's so important for us to hear your expertise. So if you hear from us again asking you to join, don't be upset. This is because we love you so much. So really. So
bye-bye. Thank you very much.
Yeah,
thank you.
Bye-bye. Thanks so much,
much,
Alexandra, Meg, Lina, Dimitri, and Will. Bye-bye. Bye-bye, dear friends.
Bye-bye.
Thank you.